Hello, everyone. Welcome to another Residency VMR. Here we are very happy, Deborah and I, to have all of you here because we have reached the last Residency VMR of this cycle. We will have more, hopefully. And first of all, thank you so much for all this amazing match cycle. We can't wait for everyone here and watching us in the recording in YouTube for the great news of your match. So you can do it. You got this. And then let me introduce the guests. Here we have Dr. Karina Suleiman. She is a program director at LSU Shreveport Internal Medicine Program. Uh, Good morning, Dr. Karina. Would you like to introduce yourself and tell us more about you, what you like doing outside of medicine?
Hi, thank you for having me again. I'm delighted to be here and represent our program, and proud of both Shreya and Anuj for putting this together. I've been program director for this program for about 7 years now, I believe. And outside of work, I am married and I have 2 children. My son is 11, my daughter is 9. So most of my time is taken up with spending quality time with my family. I like to travel. And I'm hoping to visit every country eventually. And I like to read.
That's really nice. We will really like to hear what new book you're reading. Personally, I do have some of them. I keep buying them. I never finish them. I keep buying more. So, but yeah, our next guest is Dr. Shreya Goyal. She's a PGY2 resident. Welcome, Dr. Shreya. Would you like to introduce yourself and tell us more about you?
Hi, I'm Shreya, one of the PGY2s at LSU Shreveport. So I completed my med school in India, and then I did some research at Mayo Clinic. And then I was very fortunate to be part of LSU Shreveport. Apart from, and I really like our program director. She's like one of the most supportive members of our program, and I'm really thankful to her. And apart from my medicine, I like to go to CrossFit. I like to go to gym, and on the weekends when I have time off, I like to go to horse riding. So I was an equestrian, so I try to keep up with that.
Really, that's amazing. I think I haven't met any equestrian before, but CrossFit, Deborah here, a powerhouse. She loves CrossFit. She had made us do challenges and zip overs.
Yesterday was a CrossFit Open competition, so that was really challenging.
Oh wow. And today you have rounds. Oh, that's a lot of stamina.
Did you do the open workout?
I did the open workout, but not the RX part, but the scaled part.
Yeah.
So yeah, that was my first time doing the CrossFit Open competition because I was fairly new to CrossFit. I started when I came to Shreveport. I used to do normal gym.
Yeah.
So it was really like that thrill, that adrenaline rush that comes with the competition. It was amazing.
Yes. It looked brutal. It was what, like a 20 minutes of deadlifts?
Yeah, 300 row, 10 deadlifts, and 50 double unders. So it was.
Oh wow. I'm like, I don't think I could even do like 10 burpees or like 5 double under. Yeah, no. Really bad here. And our next guest is Dr. Anush Tagle. He's a PGY3. Hello, Dr. Anush. Thank you so much for accepting our invitation. Like, I know I'll reach out to you. Deborah and I will reach out to you. And yeah, we would like to listen to you. Like, could you introduce yourself?
So I'm so glad to be here. Thank you for reaching out in the first place. I always wanted to do this, but I'm sort of a shy personality. I don't always reach out as frequently as I should. But yeah, so I did my medical school from India, from NHL Medical College, then moved here for my residency in internal medicine. A few of my passions, if I have to say, is I hate to say it, but reading is something I love. My physical exertions are something more leisurely, to say the least, and not as intense as she would like in her day to day. And other than that, I love cooking. Recently caught up with a lot of.
Oh no, I think
So I'm watching a documentary. You tend to have more time as a third year.
Dr. Anush, could you repeat what you like cooking? I think you got frozen.
Oh, I'm sorry. Are you able to hear me now?
Yes, now we're good.
So just in general, cooking meals for myself, and I love watching movies and shows. The most recent one I'm watching is the F1, and on Netflix, it's like a long documentary with various seasons. So I've really caught up with F1 and starting to enjoy it. So I'm looking forward to watching more of it.
Wow. Like F1 as in the Formula One, the racing? Or
Yes. Yeah,
oh yeah, we have a Mexican there, Checo Perez. So
absolutely. Checo Perez, yes.
uh,
I think he's with Red Bull right now.
I think so too. I just know that Mexican there, Mexican that we're going to be cheering for. So we have our discussants, Dr. Jack Petter. Would you like to say something to our family here, Dr. Jack?
Hey, good morning, everyone. Thanks everyone for being here. It's so wonderful to get to meet you, Dr. Suleiman, Shreya, and Anuj. It's yeah, thanks for coming out. It's really wonderful to get to learn more about your program, to get to learn more about you, and to all think through a case together. And Ibrahim and Shreyas, thanks for being up to co-discuss together. I'm excited to get to think through this case with you all.
Talking about our discussants, Ibrahim and Shreyas, would you like to introduce yourself, Ibrahim?
Yeah, sure. Thank you, Yaz, and thank you to all the folks from LSU Help, including Dr. Anuj, Dr. Sulaiman, and Dr. Shreya. It's truly a pleasure and an honor to be having this platform with you guys all. So my name is Ibrahim Omer, and I'm part Saudi by way of my mom, and I'm part Sudanese by way of my dad, and I'm currently a medical student based here in Saudi Arabia.
Good to have you.
So nice to be a co-discussant. I really want to thank the LSU program and Yasmin for this opportunity. I'm Shreyas. I'm a medical graduate from India, and I've applied for the current math cycle, and I'm waiting for the results, which are just 2 days away from now.
You got this, Shreyas. Thank you so much. And without any more rambling from my part, let's start with the case. And again, thank you for the sleep solvers. It's not only me, it's also Deb and all the family here. So yeah, let's begin.
All right. So the chief complaint is coffee ground emesis of 1 day and diarrhea of 4 weeks. I'll go ahead with the HPI now.
What do you think, Dr. Jack? Would you like to start?
Sure. No, it's okay. We can. Why don't you go ahead and give us the HPI?
Sure. So it's a 48-year-old female who presented to the ED with complaints of coffee ground emesis of 1 day with 5 episodes of about 5 to 10 cc's each and diarrhea of 4 weeks. The diarrhea episodes were 4 to 6, yellowish, watery, and they were associated with nausea, vomiting. Patient was feeling weak and lethargic. I have some more, if I should go ahead.
Sure. Yeah, that sounds great.
She denied any recent sick contacts, recent travel history, or eating outside. The diarrhea did not correlate with food intake and was present throughout the day as well as the night. She has no prior history of similar episodes. The patient denied any fever or chills, dark tarry stools, or frank blood in her stools as well. Rest of the ROS for chest pain, shortness of breath, dyspnea on exertion, sensory motor weaknesses were negative. I'll stop here.
Wonderful. Thank you so much for, already a fantastic case to get to dive into. Ibrahim, maybe I will start with you here. We have 2 separate complaints at this point, right? We have a diarrheal illness that's subacute in nature, and then we also have coffee ground emesis that's more acute in nature. When we think about evaluating somebody in the emergency department, obviously the coffee ground emesis is going to take first priority given the morbidity of this chief concern and the acuity of it. And I'm curious, how are you sort of initially thinking about the potential causes of her coffee ground emesis here?
Right. Honestly, when I hear the word coffee ground emesis, I mainly think of the upper GI tract. I feel the word coffee ground by itself carries a very heavy load in that it actually points towards more specific diagnoses rather than the rest. So for example, if it was food emesis, or if it was something like bile emesis, I'd be thinking about more like an obstruction. But with the coffee ground emesis, and because I'm thinking of bleeding, I'm mainly thinking of the upper GI tract, including the esophagus, the stomach, as well as the proximal duodenum, and what could result in bleeding in those areas. So I think the reflex thought that I currently have is either an esophagitis, gastritis, or duodenitis. But then also, because this patient seems to have more of a subacute presentation rather than acute presentation, I wonder if there is something else that is related to the diarrhea that could relate also to an upper GI bleeding. So say, for example, something like cirrhosis. I don't want to say everything, so I'm going to leave some ground for Shreya's as well.
Ibrahim, I think that's fantastic. And I think it's a really helpful way to anchor us into the acuity of the into the acuity of the upper GI bleed, while also recognizing that there's a subacute component to this illness as well. So Shreyas, when you see the separate finding of the sort of 4 weeks of a diarrheal illness, that seems like it's happening throughout both the day and the nighttime, how are you thinking about that chief concern? And then together, we'll layer these two chief concerns together.
Sure. I think the diarrhea component is something which is interesting here, and it's not something which was immediately brought to the attention. So again, the thing which actually brought her to the ED was the coffee ground emesis, and the diarrhea of 4 weeks is a problem which we have subsequently. So I think these are two parallel processes, and we might try to find where they meet a common ground at some point. And the diarrhea for 4 weeks, I would just employ a schema for subacute to chronic diarrhea. It's not something which is really acute. So although when you think of an acute cause of diarrhea, I think about viral gastroenteritis being the most common cause. But then here the diarrhea has been going on for 4 weeks. So, and we also know that she doesn't have any travel history or sick contacts. So we can, we prioritize that. We prioritize travel related diarrhea like typhoid illness or something which can cause an enteroviral illness, which one can acquire by travel as a less of a priority. But then I think the fact that I just like to approach diarrhea in the form of, you can approach it in different ways. The fact that she's having diarrhea even at nighttime is also concerning. So that makes me prioritize secretory type of a diarrhea. So those are my initial thoughts with the diarrhea at this point.
Excellent, Shreyas. I think you highlight a really, really important dimension of her diarrheal illness, which is the time course here. 4 weeks is a challenging cutoff in that it is sort of the beginning of the chronic diarrhea phase and the end of what we can sometimes consider acute diarrhea. And I love the way that you broke down the most common causes of an acute diarrheal illness are going to be infection, and then everything else. But the longer the diarrhea lasts, the more the probability of a non-infectious diarrheal illness comes up. Those could be non-infectious inflammatory causes of diarrhea. And are there any, and I'm curious for you, are there any non-infectious inflammatory diarrheal illnesses that start to come to mind?
Sure. I actually think of right now, although the age does not fit, I'm really thinking of inflammatory bowel disease, although it's atypical that it can present at this point of time, and also thinking of a variety of endocrine conditions which can present with diarrhea, like a VIPoma, although I'm sure it's pretty rare at this point, and also thinking of some of the neuroendocrine tumors which can cause secretion. So those are some of the initial thoughts with the secretory type of diarrhea which can present in this manner.
Excellent, Shreyas. I love the way that in the inflammatory category of chronic diarrhea, you're bringing in non-infectious inflammatory diarrhea like inflammatory bowel disease. And then the other non-inflammatory causes of chronic diarrhea, secretory and osmotic, you've made a great case for why we might prioritize secretory diarrheal illnesses. Osmotic diarrheal illnesses, the diarrhea develops because something passes into the lumen of the intestines that carries a big osmotic load with it, right? In the case of somebody who's lactose intolerant, that could be the lactase enzyme, or it could be other gastrointestinal irritants, like, for example, certain components that include FODMAPs. But the secretory diarrheal illnesses tend to be persistent throughout the day and night. And so I think you did a phenomenal job of highlighting that as a key consideration here. Ibrahim, before we move on, I'm going to come to you. Shreyas mentioned the possibility of inflammatory bowel disease. And I think it's helpful for us to review the different categories of that just to get our minds primed before the rest of the case unfolds. If this were to be inflammatory bowel disease, does one seem more likely than the other, given the locations of the GI tract that may be involved in terms of upper and lower? How do you think about IBD in terms of which components of the GI tract they hit?
I'm definitely with the upper GI involvement. I'm definitely thinking more about Crohn's. However, I do have to say something that I think a lot of the gastroenterologists made sure to emphasize during my rotation, which is that oftentimes, even though we like to categorize IBD into Crohn's versus ulcerative colitis, it's very likely that sometimes you cannot differentiate between either of the two. So just saying IBD can sometimes be sufficient to point towards a diagnosis.
I love it. Excellent point, Ibrahim. All right, Shreya and Anuj, take us forward.
Can I just add one more point before we move forward? I'm so sorry to interrupt.
Of course.
I was also thinking about the secretory causes, and one thing which just came to me, although it's too early to think of a single unifying diagnosis, I was also thinking, when you think about secretory, we either think about something which is either secreting a toxin, or we have something which is endocrine secreting something. I told about VIPM. I was also thinking about the possibility of a gastronoma. So you can also have diarrhea because of so much of the hydrochloric acid, which kind of washes away the mucus. And also, if I were to unify and think of the way in which it could present with a coffee ground emesis because of a gastronoma, it could be because of a gastric ulcer, which is probably bleeding. So that's just something which I was thinking of while we were having this discussion.
Excellent, Shreyas. Thank you so much.
Those are all very fascinating inputs. We were similarly thinking along the same lines. I would still go ahead and add something more to the HPI, because this patient was seen at our hospital after 2 visits at an outside hospital. So I'll go ahead and give some information about that. She was admitted at an outside hospital on 2 separate occasions over the last 4 weeks. Her initial admission, she was diagnosed with enterocolitis on clinical impression and imaging, and she was managed conservatively and discharged. On the second admission, she had similar complaints. At the time, she was diagnosed with biliary dyskinesia on a nuclear hepatobiliary imaging, and she underwent an laparoscopic cholecystectomy. That's all for the second aliquot.
Shreya, I'm sorry. Shreya and Anuj.
Yeah.
That's all for the second aliquot till the cholecystectomy.
Anuj, you cut out just briefly there, just to make sure, do we have everything correct? The biliary dyskinesia to the lap chole, so that's the key information there.
Yes, so 2 separate occasions. On the first occasion, diagnosed with enterocolitis, managed conservatively. The second time, patient was admitted for biliary dyskinesia and underwent a lap chole. Yes.
Thank you, Anuj.
Yes.
All right. So maybe we can just take a brief foray into this initial information. Shreyas, how is the new data that we got about the previous hospitalizations modifying your initial impressions that we just talked about?
To be honest, it's not really modifying what I'm thinking of too much. That's because these were the similar type of complaints which she also had. And I see there's a procedure for biliary dyskinesia for which she got a laparoscopic cholecystectomy. Initially, I was thinking maybe the cholecystectomy could possibly explain the diarrhea, but then she had the diarrhea even preceding the cholecystectomy. So I'm not really sure whether that could probably influence the diarrhea. So at this point of time, I'm still Not really sure how I can tie in her previous hospitalization to how she's currently presenting.
Excellent, Shreyas. Those are fantastic points. Ibrahim, anything else to add here?
I'm definitely thinking along the same lines as Shreya's. I do wonder if the cholecystectomy is noise rather than actual complaint that this patient had. I remember a case that we've had a couple of weeks ago of acalculous cholecystitis. So I wonder if this could be related to her underlying disease rather than a symptom of presentation. And just getting back to the IBD, when I first heard about the laparoscopic cholecystectomy, I thought of primary sclerosing cholangitis, but I know that most likely since they did the cholecystectomy, they would have done imaging beforehand. And if there was PSC, most likely it would have been mentioned at this point. So that also changes the way I'm currently thinking about IBD for this patient.
I will say it is so wonderful to hear. I can see the ways in which you all are starting to pull in other disease entities and other pieces of the illness script for the different diseases that we initially considered here. One thing that is, I think that this new aliquot is reinforcing for me is the challenges of assigning somebody the diagnosis of gastroenteritis and then not knowing exactly how they follow up. Because we see here that there was a clinical presentation very compatible with enterocolitis, acute onset diarrhea with imaging findings. It sounds like suggestive of colitis. And one of the things that I'm always reminded of is that colitis when we see colitis on cross-sectional imaging of the abdomen and pelvis, it actually opens a whole other door into other disease considerations. There is a long list of things that can cause enterocolitis on imaging, and really it's the 4 I's. We can have infection, inflammatory diseases, ischemia, and infiltrative diseases. And it's very difficult to differentiate between those 4 based off of cross-sectional imaging alone. Oftentimes, we need endoscopic imaging and potential biopsy to be able to further characterize what exactly the underlying cause of the enterocolitis is. And so in this case, whenever we assign somebody a diagnosis of gastroenteritis or enterocolitis based on clinical and imaging findings from the emergency room, we can oftentimes do it with a high degree of confidence, but the diagnosis hasn't necessarily been fully confirmed until the person recovers under the expected time course. In this case, she has not recovered under the expected time course, and so it's key to revisit that working diagnosis of acute enterocolitis, which is usually from an infectious cause. And so just remember, enterocolitis on imaging does not confirm infection. It merely confirms colitis, and then we have to think about those 4 I's: infectious, autoinflammatory, ischemia, and then certain infiltrative diseases like lymphoma, for example. In this case, as you all have mentioned, ischemia seems less likely, but the autoinflammatory diseases, given her age range, certainly occupy a large probabilistic proportion here. All right, take us forward.
The past medical history, patient has a history of cervical cancer, status post hysterectomy. Currently on chemotherapy, but the regimen is unknown. She has a history of diabetes, type 2, hypothyroidism, and hypertension, obesity, asthma, and DVT, which was diagnosed in 2023.
Just to clarify, it's hypothyroidism.
And then coming to the medications, okay, she is on amlodipine and losartan for hypertension, and she's on apixaban for DVT, and then levothyroxine because of the hypothyroidism. Family history is no significant family history. Social history, she denies smoking, alcohol, or any drug use. Allergies, she's allergic to sulfonamide antibiotics and hydrocolone.
Go ahead and okay. Do you want us to stop here? Or do you want to give us the vitals and the exam? I leave it up to you all.
We apologize we are experiencing some connection delays for some reason.
That's okay.
But we're here
Yeah.
if you would like to add or change something at this point.
Sure thing. Ibrahim, what are your thoughts here, specifically looking at some of the past medical history and the medications? Again, we're sort of still in the game of both identifying where the center of gravity in this case is and shifting the different probabilities at play here. So how is this influencing things for you, if at all?
To be honest, when I look at the past medical history, I think what catches my eye and what catches probably everyone's eye is the history of cervical cancer. I think that by itself, especially that it's not a history, it seems that she's still being treated for cervical cancer. I think that introduces the fact that this patient is, one, immunocompromised. And so again, it raises the threshold for an autoinflammatory disease, but it also raises the threshold for a side effect of the medication that you currently have, or another infectious etiology that is contributing to her current symptoms. I think that what caught my eyes off guard first, and what I'm still thinking about right now.
Excellent. Shreyas, anything to add?
Fantastic. I completely agree with Ibrahim, and he spoke about the cervical cancer, but I see two more things in the history which are kind of concerning for me is hypothyroidism and diabetes. Just wondering, there are two endocrine conditions we're dealing with here, and I can't help but think about an autoimmune kind of a pathology here because there's both thyroid, which is involved, and also there's also diabetes. So I'm thinking more on the lines of maybe an autoimmune polyglandular syndrome, which can possibly result in both. And then now when I tie that in with the diarrhea, which is being present for 4 weeks, I'm thinking of celiac disease as well, because she's having multiple because I'm thinking along the lines of one autoimmune disease, you think about multiple other autoimmune diseases. So that was one of my initial thoughts. And also I was thinking about this could very, very well be type 2 diabetes, but when I saw DVT, I was also thinking glucagonoma can do that. For example, it can cause secretory diarrhea, it can cause diabetes, and it also predisposes people to DVT. So those are two of the thoughts which crossed my mind when I was trying to think about this aliquot of information and tie it in with her current presentation.
So I will say you both are light years ahead of me. I think I'm still in the process of trying to clarify where exactly the primary problem is in this case. I think when we initially received the information from Shreya and Anuj, we heard that this seems like it's a disease that potentially spans the entire GI tract from the upper GI through the lower GI system. And seeing the history of a DVT and the current active anticoagulation, it made me question how much the upper GI tract is really at play here. Certainly, we see features of an upper GI bleed, but somebody who has been having diarrhea, nausea, and vomiting for several weeks, a Mallory-Weiss tear is a completely understandable complication of that ongoing process that could lead to some coffee ground emesis over the coming days. And so I think what this aliquot does is it makes me question the initial way that I was framing this, which was an upper and a sort of mid to lower GI disease, and potentially all of the action may actually be in the lower GI tract, and the combination of chronic GI symptoms plus anticoagulation led to some mucosal irritation and a GI bleed that certainly deserves attention in terms of its management, but may not necessarily be a key framing from a diagnostic perspective. And so I love the considerations that the two of you brought in terms of thinking about how can we start to tie these together. And I think I'm still in the process of trying to decide how exactly do we frame this problem here. And then hopefully the exam and then any other advanced studies will help give us some real clarity on the problem space that we're dealing with. Is this a pan GI illness or primarily a mid to lower GI illness that brought the upper GI tract along for the ride?
Those were some great thoughts. Okay, coming to vitals, she is afebrile. She's afebrile and heart rate ranges from 100 to 110s, and blood pressure is 100 over 60s. Respiratory rate is 18, and she's saturating 98% on room air. An exam, generally, the patient is ill appearing in acute distress. Head and neck, dry mucous membranes. normal extraocular movements, no lymphadenopathy, no thyromegaly. Extraocular movements. Cardiovascular exam, S1, S2 was normal, no murmurs. Pulse was regular. Rhythm was regular as well. Pulmonology, clear to auscultation bilaterally, no additional sounds. Patient.
Can you hear us?
Yeah. On abdomen examination, diffuse tenderness on palpation, no guarding or rigidity. No hepatosplenomegaly, no guarding as well. Neurological examination was within normal limits, and on extremities, no rash, no edema, no lesion.
Why don't you, just to make sure that we have plenty of time for the full discussion, feel free to give us the initial labs and then any other sort of initial imaging, like CT scans, if they were done.
Sure. WBC was 9.6, hemoglobin 15.1, platelets 305. Okay. CMP sodium was 138, potassium 3.1, chloride 113, bicarb 13, BUN, we have not written BUN, creatinine 2.2. BUN was, I think,
BUN was in the
50s,
50s, and creatinine baseline was 1.
Yeah, creatinine baseline was 1. Calcium was 7.9. Albumin was 2.2. So corrected calcium was within normal limit. LFTs were normal. Lactate 1.01. Lipase was 26. And then CRP 21.6. Imaging, so I'll tell the pertinent outside hospital labs also. So at outside hospital, her C. diff was negative. The GI biofire, which is like a rapid PCR panel for various organisms, was negative. CRP at the outside hospital was 1.24. And the fecal calprotectin was 106.
Which was borderline elevated.
Yeah. 106. So CT abdomen pelvis at this admission was fluid-filled small bowel and dilated colon measuring up to 7.6 centimeters with mural thickening. 。 . 。 . 。 . 。 . 。 . 。 . 。 . . 。 . . . . 。 . . . . . . . . . . . . . 。 . . . . 。 . . . 。 . . 。 .
。 . . . 。 .
7.6 centimeter.
EKG was just sinus tachycardia. We'll stop here. We'll give some additional information after.
All right. Well, we have made some excellent progress here in being able to characterize the syndrome at play here. Ibrahim, I'll turn it over to you to start first. And I leave it open to you in terms of which, talking about the exam, the labs, or the imaging studies. But I think this aliquot helps us start to move forward and start to narrow our focus a little bit. And I'm curious the ways in which that's happening for you.
To be honest, for me in the exam, I don't see something that is particularly concerning or something that wouldn't have been expected upon hearing the HPI. I would have been more concerned if there was rigidity, guiding, or rebound tenderness, but it doesn't seem that this patient has either of these. She seems to be vitally stable, even though she's a little bit dehydrated. When it comes to the labs, I think what really strikes me is her creatinine and BUN. So it looks like she has some sort of pre-renal azotemia, which makes me once again think about cervical cancer, especially considering that renal failure is the #1 cause of death in patients with cervical cancer. I wonder at which stage was this patient at to the point that they had to get all of her uterus out in order to treat her cervical cancer. But that being said, it could also be related to her dehydration and vomiting, as well as diarrhea. And the other point, and the second point that I also wanted to comment about, is the fecal calprotectin. So I know that the fecal calprotectin is oftentimes used within the context of IBD. That being said, I also know that it doesn't entirely point towards IBD, but could relate to really anything that could result in an immune system mounting a response towards the GI tract. So things that would go all the way from infectious etiology to autoimmune etiology would result in an elevated calprotectin. And then finally, for the imaging, again, with the elevated calprotectin, I wonder if there's an underlying lymphoma, especially with the mural thickening, that could be promoting the symptoms that this patient has. But I'll leave the rest to Shreya's and to you, Dr. Jack.
I love those points there, Ibrahim. I think it's a really important take-home point that the fecal calprotectin is sort of like the ESR and CRP of the stool. It tells us that inflammation is there, but doesn't necessarily tell us the nature of that inflammation. Shreyas, I'm going to come over to you, and I have one question to start off, and then I'll leave it open to you to share whatever other thoughts you have. But we see this hemoglobin of 15 here. We see some of these vital sign changes on exam. I'm curious, right? We are both in the DX and we are in the TX business here. And so we initially talked about the acuity and the importance of managing the upper GI bleed. And I'm curious how you're thinking about the significance of the GI bleed at this point in time, given the information that we have.
Sure. I think that given her hemoglobin of 15.1, I don't think she lost a lot of blood because of the coffee ground emesis. So I would always want to go back to the patient and just, if possible, ask if she could quantify how much of the emesis she could actually see for herself, and how much of blood she could see. So I think that would give me a lot more data to deal with. But then just going by her vital signs, it just seems to me that she's dehydrated. The heart rate is slightly high, and also the fact that she seems to have, when I look at the sodium and I look at her electrolytes, it seems to me that she has a normal anion gap metabolic acidosis. Her anion gap is around 12. And just the BUN and creatinine is also elevated, which can also mean there's some sort of pre-renal azotemia, like Ibrahim had mentioned. And the BUN by creatinine is around 25 here. So I think that we are dealing with volume loss. How much of that is blood is something which I'm still not sure about. But just looking at her hemoglobin, I think she's not lost a lot of blood, and I don't think she needs a transfusion at this point of time. So those are some of my initial thoughts. And when I was also looking at the imaging findings with the mural thickening. I was not really sure how to tie that in. I was thinking it could be inflammatory bowel disease, but then I just want to step back and look at her past medical history. She did have cervical cancer. I want to know what kind of treatment was given, if there was some sort of radiation which was involved. So I would also think about some radiation changes and radiation-induced colitis, which can actually explain some of her diarrhea. So those are some of my thoughts, and also maybe radiation. Maybe she also got radiation to the around the esophagus area, which could cause some esophageal changes, and also explain the coffee ground emesis. So those were my thoughts with some of these imaging findings.
Excellent, Shreyas. I think I am with you 100% in terms of the analysis of the GI bleed, and how that analysis plays over into the management perspective is we see that this isn't necessarily an unstable upper GI bleed at this point yet, but there is some concerning features. And I love the way that you framed it. There is volume loss here. The component of that is just volume from diarrheal illness versus volume from blood loss is difficult to ascertain. And so in a moment of uncertainty like this, when there's a morbid diagnosis at play, we would err on the side of caution. We would say, I'm going to treat this person like an upper GI bleed, start an IV PPI, make sure to volume resuscitate them effectively. She hasn't met criteria for a transfusion at this point, but we're going to still think about preparing those things so that we have it available. As she gets volume resuscitated, we may see that hemoglobin of 15.1 fall to as low as 10, 9, or even 8. Because in the acute phase of blood loss, right, the individual loses all of their blood volume. And so they won't necessarily reflect a change in the hemoglobin concentration until we've given some of that fluid back. And so I'm with you. We are sort of in this middle ground. It seems like there's an upper GI bleed at play. We have some time to better understand the severity, but we still want to start to work to get ahead of it. I have nothing to add to what the two of you said in terms of the significance of the CT findings. I think for me, mural thickening translates into colonic inflammation here, and that inflammation still falls back onto those 4 eyes we talked about at the beginning. It's very difficult to discern between each of those eyes based off of imaging findings alone. I have thought it was going to be IBD and it ended up being ischemia. I have thought it was going to be ischemia and it ended up being an infiltrative cancer. And so given how many times I have been wrong here, I have shifted towards saying, I know that this is a cue to get more information, and that more information oftentimes involves a mucosal evaluation on endoscopy and then potentially a pathologic evaluation with biopsy.
Great thoughts again. We'll go ahead and give you some more information now. We were all thinking along the same lines when we were admitting this patient. Now, we were admitting this patient overnight, so we couldn't really get hold of a lot of information until the next day with the help of the day team. So we obtained some collateral information from her oncologist, and it revealed that the patient was on an immunotherapy. And it was being given. The last dose was about 1 to 2 weeks prior to the onset of her symptoms. We have some stool studies that we had taken at our institution now. Calprotectin was 668, stool leukocytes. Stool was negative, diff was negative, but CMV serology was positive for IgG. If you would like, I can go ahead and give you some information with the scopes as well.
Let's actually pause here because I think that this is an important pivot point for us to be able to consider before we go into the endoscopy results. So Shreyas, you and I and Ibrahim, we are the team taking care of this patient in the hospital. And we obtained this new collateral information about the presence of recent immunotherapy. How is this adjusting the potential diagnoses that you're considering and the probabilities of those diagnoses?
Sure. This is some really interesting information. Now that we know that she's been getting some sort of immunotherapy, I'm really thinking along the lines of immunodeficiency. So that's where I'm headed. And then when I think about immunodeficiency and how I tie that into diarrhea, I'm thinking about all the infectious agents which can cause diarrhea in an immunodeficiency patient. And we have CMV IgG positive, but I'm not really sure how to deal with that information because I think we still need tissue to ultimately establish the diagnosis. So those are my thoughts with the information we have right now.
Excellent, Shreyas. I love fantastic points. Ibrahim, what else? What else do you have to add?
Yeah, to be honest, not a lot to add. Just mainly thinking about some of these side effects that could be related to her immunotherapy. So I think at the top of my differential now, I know that colitis can be very likely in this case, given the immunotherapy. And then also adding up to the CMV, you know, and the fact that she's immunocompromised. So at this point, I think I would further investigate what kind of immunotherapy she got and if they could be related to the symptoms that she currently has.
So we found out that the patient received pembrolizumab a week before her initial onset of symptoms.
Okay. All right. So just to add a couple points to what was discussed here, I think if we can use this presence of immunotherapy to really kind of build out the same framework that Shreyas and Ibrahim mentioned, which is there is complications of immunocompromise from immunotherapy, but there are also, and far more common, complications of the actual therapy itself. And so what the immunotherapy does is it tunes the immune system to how do I say it? It tunes the immune system to direct the immune system response towards the cancer cells in the body. That does an incredibly effective job of addressing the cancer, but sometimes those tuned immune cells may start to work against other healthy tissue in the body. And the general category of this is they're called IRAEs, IRAEs, immunotherapy-related adverse events. And there is a long list of different immunotherapy-related adverse events, but there's a couple that are worth having in your back pocket on speed dial as some of the common ones. One of the common ones is an autoimmune hypophysitis, and so we can see features of panhypopituitarism from immunotherapy-related events. We can see colitis, we can see pneumonitis, and we can sometimes see the development of diabetes as well. So in this case here, whenever you see someone on immunotherapy with localizing symptoms to the organs, we have to ask ourselves if those organ-based symptoms are related to the immunotherapy. But establishing the diagnosis is difficult because it also requires falsification or exclusion of all of the other alternative causes of diseases in those organs. We need to rule out the infections, which can be challenging because these individuals who get immunotherapy are often immunocompromised. We have to rule out, in this case, the other causes of colitis, like ischemia and autoimmune disease. And then finally, we want to make sure that we rule out infections, and which I think actually I may have already said. I agree with you both. The CMV IgG positivity is hard to know what to do with. If you sample everyone here on this VMR for CMV IgG, the vast majority of us will probably be positive. And so we really need evidence of either high levels of viremia or the key pathologic findings on biopsy to prove that this is indeed CMV colitis and or disseminated CMV. So it's certainly possible, but I agree with both of you. PATH is going to help us here because it will allow us to evaluate for those 4 eyes. And if all those come out negative, then we may be dealing with checkpoint inhibitor related colitis in this case.
These are amazing thoughts. We were thinking similarly along those lines once we found some additional collateral information. So we went ahead with a EGD, which identified grade B esophagitis in the lower third of the esophagus, diffuse gastritis, and some mild erythematous duodenitis at the duodenal bulb. Then we also went ahead and performed a colonoscopy. Severe right-sided colitis was seen and mild left-sided colitis without any ulcerations. We'll stop here.
All right. So we have an illness that is affecting the entire GI tract at this point. And it seems like what we're primarily seeing is inflammation, but the absence of ulcerations, the absence of erosions, the absence of ulcerative predominant diseases, and what seems like a fairly continuous or contiguous inflammation throughout the areas that are affected. So Ibrahim, I'll come over to you first here. How are you thinking about this now? How does this shift the different probabilities?
Honestly, it makes me think more of so the fact that there isn't really any skip lesions that we can see, or any histological landmarks that could point towards one IPD from the other, makes me think of a side effect to the immunotherapy that she got. I think what I'll be concerned about next for this patient is how to relieve her symptoms, and how to overcome this side effect from ever happening again if she gets another dose of her medication. But yeah, this is where I am at right now.
Excellent. Shreyas, anything else to add?
Nothing more to add. And actually, the immunotherapy-related side effects for the GI tract is a knowledge gap for me as well. I'm really interested to know where this case is headed and learn more.
Yeah, I'm with you. I think if we start to map on these endoscopic findings onto either characteristic Crohn's disease or characteristic ulcerative colitis, there's features that don't necessarily fit, right? Crohn's disease, we expect to see skip lesions, as you mentioned, Ibrahim. Ulcerative colitis, we may expect to see primarily colonic involvement. In this case, we kind of have features of both. We have primarily an inflammatory findings in the GI tract with esophagitis, duodenitis, gastritis, and colitis. But we don't have the erosions or abscesses or other things that we can see in IBD. So while the whole GI tract is involved, it's not, the phenotype isn't what we would expect to see in Crohn's. And while it may have a phenotype of ulcerative colitis throughout the entire GI tract, we wouldn't necessarily expect ulcerative colitis to make it all the way up into the esophagus. As Ibrahim mentioned at the beginning, right, every case doesn't necessarily read the textbook, so there can be overlapping features. But given that we have a compatible alternative diagnosis in terms of checkpoint inhibitor-related disease and endoscopic findings that don't map characteristically onto either one of the inflammatory bowel diseases, this does, I think, for me, ratchet up the possibility of checkpoint inhibitor, pan-GI-itis. But again, that's going to, we formally are going to establish that diagnosis once we falsify all of the other causes. So no infectious findings are seen. We really make sure that the pathology doesn't show features of ulcerative colitis, which can be hard because the path can look very similar across these different diseases. If we think about it, IBD, ulcerative colitis, and immune-related or immunotherapy-related colitis, they are all the immune system responding to the GI tract in an abnormally attuned way. And so it can be difficult to formally establish the diagnosis, but at the very least, as you both said, we're going to think about potentially holding the pembrolizumab before we get further clarity on this finding.
Should we go ahead with some additional information? All right. So we were in a diagnostic dilemma after looking at these results, whether this could be infectious colitis or this is possibly a side effect of the immunotherapy. We ordered the CMV PCR levels, the DNA levels, HSV1 and 2 DNA PCR levels, which were still in the works. They were still getting processed. However, given the overall evidence and absence of ulcerations, our likelihood of having an infectious colitis went down, and the distribution suggested that this could very well be a possibility of an immune checkpoint inhibitor colitis. So we went ahead and started the patient on empirical methylprednisone with close monitoring to see if the condition improved or worsened. The other thing was IgM CMV was negative. That gave us some more confidence as well in the meantime until we had some results. So eventually we started noticing improvement in the patient's symptoms. The CRP improved from the 21 to 4 over time. And we had the EGD biopsy and the colonoscopy biopsy results. The EGD was negative for H. pylori, but it demonstrated increased lamina propria lymphoplasmacytic infiltrates and apoptosis in the crypts. In the colonic biopsy, it was demonstrated there was cryptitis, apoptosis, and lymphoplasmacytic infiltrates, and no inclusion bodies were observed in the biopsy as well. Finally, CMV DNA PCR and HSV DNA PCR were negative as well. Patient gradually improved and was started on taper dose prednisone. Final diagnosis was immune checkpoint inhibitor gastritis and enterocolitis.
And we also got to know that the recent hypothyroidism the patient had was also a side effect from the immunotherapy. So it was recently diagnosed hypothyroidism. So everything, all the three things, gastritis, enterocolitis, and hypothyroidism, all started because of the immune check, were all the side effects of immune checkpoint inhibitor. And pembrolizumab is like a notorious drug in terms of causing these side effects.
Shreya, that is such an interesting twist to this case. Can I ask, was it primary hypothyroidism or secondary/tertiary hypothyroidism? It was primary. Okay. Very interesting. Very interesting. Wow. Well, what a case. Shreya and Anuj, thank you for bringing this to us. This was a fantastic discussion to get to, or a fantastic case to get to think through. Ibrahim and Shreyas, I hope the two of you are feeling incredibly proud right now because you both analyzed and dissected that case with such clarity and such dexterity. And so I'm just so in awe of what you both just did. Really, really well done. Before we turn it over to the Shreveport team, I just wanted to give each of you some time to share any reflections on the case or anything else that you want to share.
Oh, yeah, I'm actually very glad and honored to have had the chance to actually share the stage with everyone here today. So Dr. Jack, thank you for facilitating the ongoing discussion. Dr. Anuj and Dr. Shreya, thank you for actually bringing on this case. I think, the case actually took a shift when you guys said that you got collateral information that the patient was on an immune checkpoint inhibitor. And I think, oftentimes the residents that really teach me the most are the ones that seem to have the best interaction and communication with their patients. And I can see that evident for both of you guys. So thank you so much. And Shreya, it was truly a pleasure to have this stage with you as well.
Ibrahim, thank you so much. I also want to thank the whole LSU Shreveport team, Dr. Shreya, Dr. Anuj, and Dr. Jack. I learned a lot through this case. It's definitely something which I was not expecting as we moved along the case. And immune checkpoint inhibitors, I think this is maybe the third or the fourth time it's been a culprit on the CP Solvers cases. I think we had one of the cases which was a drug fever, and the other one was an immune checkpoint inhibitor lichen planus reaction. And now we have two manifestations of it, one in the form of colitis and also the hypothyroidism. So this is new to me that it can also cause hypothyroidism. So I learned a lot while discussing this case. Thank you so much.
Thank you so much for such positive comments, everyone.
Yeah. So when we were like thinking about this case, we were like, okay, it might be easy case, but then we thought, okay, immune checkpoint inhibitors and the side effects to them, it's like fairly new and not a lot of people are aware of these. So I think it was we wanted to bring this like awareness that, okay, this can also be a side effect and can present like with so many, it can affect a lot of organs.
Thank you so much for bringing this case. It was really educational and it was a really great discussion in Burring, Sherrod, and Jack. Thank you so much. Yeah, now we have some space like for some questions, and as we have the program director here, if she wants to talk a little bit of the highlights of the program, something that she want to share with us, we will be happy to hear from her.
Thank you so much. I really enjoyed hearing the case. I also want to introduce our Associate Program Director, Dr. Bhayani. We were both on kind of backup for this because we're actually both on service today. And so I do apologize for switching off my camera here and there, but some stuff was going on. I'm a nephrologist by profession, so I'm on call for nephrology, and he's on as a hospitalist. So great case, guys. We're so proud of the way you showcased not just our interesting cases, but also, how you led the story. And I'm a nephrologist, so I'm going to throw in that You can also get nephrotic syndrome from checkpoint inhibitors, and it was just too much to start exploring that part of that creatinine. So I'm going to let that be, but ask later if it got better or not with hydration. But yeah. And so, yeah, I mean, we are located in Shreveport, Louisiana, which is about a 5-hour drive from New Orleans. So I think that is a little confusing for a lot of people that have not been here. We are actually closer to Texas and a good 15, 20 minutes from the border of Texas than we are, New Orleans. So it's a little bit of a more Tex-Mex culture than it is Cajun culture as far as the city itself. So I've been here, this is my 20th year living in Shreveport. I came here to do my residency and ended up being a fellow and wanted to be a clinician educator forever. And so opportunities arose and here I am as the program director. So that was just a little bit about me. The program has 4 associate program directors, each of them in charge of certain things. Dr. Pani is in charge of didactics. Grab a chair, this looks weird. My bodyguard is here to make sure like none of you all bounce at me, no. And then, we are, I guess, traditionally, used to, as far as when I came, favor like most general internal medicine residencies and large programs, the more like inpatient strength and core and ICU and sick cases. I would say that in the last few years, we've tried ourselves to shift that focus into having ambulatory care being as strong a piece of it as inpatient. So we do follow a 4+1 schedule, which is an ambulatory block schedule. And originally it was variably popular, but now everybody's understood that work-life balance is important. Other things that we focus on are wellness. We have a very robust wellness committee that organizes retreats and things every quarter and wellness sessions within our didactics. I think about 2/3 of our residents match into fellowships. So it is by the nature of itself, subspecialty popular for those who want to do subspecialists. Although I personally, the program director, I'm always trying to convince people to consider some primary care because I do believe that's the need of the hour in our country. But it is what it is. So that's kind of the, so in terms of that, we do have we try to set our residents up with mentors early on so that they can, fulfill their dreams, be exposed to research. I'm glad to see Anuj and Shreya here already kind of representing the best of us, doing their part as far as research is concerned. Also, Anuj is on our clinician educator track. So we have a clinician educator track, a POCUS curriculum track, point of care ultrasound. And this year we just launched a hospitalist track. So there are some opportunities to kind of carve a niche for yourself while you train in general internal medicine. Am I missing anything, Dr. Bhayani?
I think one of the big things for our program, right? We are a large university-based program, but one of the missions of our being in our community as we cover the tri-state area is also to engage with our community. So the residency is quite like heavily relies on the residents engaging with the community. So we do have a lot of community outreach kind of built into our program. More so it's being like nationally recognized as well recently. The other thing, because this is relevant to being on this podcast, Anuj and another faculty member, one of our core faculty members, do run a resident interest group, for lack of a better term, that focuses entirely on discussions around clinical reasoning in medicine. And part of why we're here today is also to support them and kind of talk a little bit about that as well. And I think it's gotten a lot of popularity just within our residency programs. These are just some of the unique features that our program has, and we're just excited to talk to you about it. So reach out to us if you have any specific questions about our program. If you are setting up one for your own residency program, this is something we can maybe like talk about and certainly be a resource. And if you have any ideas for us, do share them with us by email. So thank you for attending our morning report today.
Thank you so much. We really enjoy how insightful your teaching, your perspective were. And yeah, thank you. Like we were looking at your IG that you had this volunteering outreach community in Providence Health, that you had wellness, that you have like this amazing like bonding session, like truly bonding sessions, and it's very important. We also know that your program has a lot of IMGs. I can tell you that here I see almost all of us are IMGs, and we would like to hear your perspective, Dr. Anush, Dr. Shreya, Dr. Karina. Please let us know how is it Louisiana for IMGs, and how can we be better prospects for your program?
We'll let the residents start on that one.
So Louisiana, I mean, I never traveled to Louisiana before. This was my first time coming to Louisiana, and I found like most of my time is in the hospital, and like sometimes we go out. I never felt like scared or anything. I felt the people in the program are very supportive, very nice to each other. I think because it's a IMG heavy program, everybody, you know, kind of like very kind to you. They understand your struggles coming to a different country. I think that really helps. And also I think the community has been very great. Like we go out, and I've never felt like intimidated or something like that. So I really feel that it is a very accepting community, and I really enjoy being here.
I can add to that. I've been just a little over a year ahead of her, one more year in this part of the country. I think it has been a wonderful experience so far. I've come and so far, and I feel I've grown so much over the past 2 to 3 years that I don't think I probably could have from the experiences I've had so far. Our program comes across as a very simple, and it's very involving and lets you grow at your own pace. That is the best way I would put it. If you are intimidated by being an IMG, not getting enough exposure in this country, this program, regardless of what your background is, what your achievements are, it takes into complete consideration what you could bring to the program. And what really matters is you at the end of the day, and how you put your best foot forward, and they are there to support you all along.
Yeah, and like our program is very receptive to like anything new. Like me and Anuj and Dr. Bruno, we thought of like deciding this clinical problem group, a reasoning group. So we discussed with Dr. Suleiman and our APDs, and they were all very supportive of that. They were like they motivate you to if you have something new ideas and something like that. So I think it helps you grow. It brings you some confidence to make changes if you feel like. So I think that I really appreciate that supportive environment.
In addition to that, I can talk a lot about what all we can offer in terms of research. We have everything that could make you a better applicant down the line for if you choose to go into any fellowship. There are resident-driven studies, there are resident-driven research work, as well as faculty-driven work, which you could be involved in and publish and move forward to what you want in your life. So there is ample opportunities to achieve whatever you want. Your wellness is well taken care of, and you have abundance of learning in line with the modern developments in terms of focus, be it clinical reasoning, or it could be anything that you want to bring to the program.
And just like to add last point that we in like Shreveport, we have so many diverse cases. Like we rotate in various facilities. We have a VA hospital. We go to Monroe, we go to Shreveport, and like it's one of the major hospitals.
I think
You got cut off again.
they got cut off, but yes, I actually did want to.
North of Lead, or like all. Yeah.
And then I'll say something. So I guess what I wanted to say is that when I joined here as a resident, we didn't have the focus and the hospitalist and the clinical reasoning. But the thing that really attracted me to choose this program was actually that we are a safety net hospital for the indigent patients in this community. of more than 100-mile radius, spilling into Texas, spilling into Mississippi, spilling into Arkansas. It's just the way we're located at the corner of the boot, as they call it. And that has not changed. And to me, it's still one of the biggest draws, because I think at the end of the day, these are all wonderful things, and we will, of course, continue to develop them. But you want to be a well-experienced internist. And when you are looking for a job somewhere else, people still call us and say, we want more of yours, because when they come in, they're ready to practice independently. And I still think this is kind of the number one goal for a future internist, is being confident in their abilities to take care of patients at all levels of acuity and from all walks of life. So I still stand by it. I think this is the thing the program does the best, and what really kept me here all these years too, because it is the place that never says no to any patients. And I think that is worth mentioning, that is a way that applicants can use their power to focus on programs and hospitals that do that in healthcare.
Thank you so much for all this amazing information of your program. It's very important to know that there are programs here that really invest their time and research, mentorship, wellness, and not only that, but also creates great clinicians for the population. So thank you. This is one of the goals of having Residency VMR. So more applicants can see that there are programs that maybe I didn't know that there was one, that Louisiana was too close to Texas. I'm San Antonio, so it's like, oh wow, it's so close home. And so it's very good to know this, and thank you so much. I think we could all see how you did an amazing job training this patient. So unfortunately, we have arrived to the end of our session today. Thank you so much for trying to be very mindful of your time. Deb, would you like to say something before closing?
No, we felt the love from the Zoom, from the program and everyone. So it was really good to have you all here on this session. It's a pleasure for us to being able to do this kind of episode. So thank you so much, and good luck for everyone applying that will receive the news this year. And we will continue having the sections for the next cycle, and we all would love to have you back. So thank you so much.
Yeah, thank you, really. We hope to have you next year, Dr. Sulaiman.
Well, I don't know. Shreya can force me into one of these again. I need to be long gone.
We'll love to join again. Thank you so much.
Definitely. Thank you. And everybody, lots of success this Monday.
Good luck, Jeff.
Thank you so much,
Thank you so
everyone.
much.
Bye.
Bye.